Hi, my name is Anna Miserocchi. I am a consultant neurosurgeon at the National Hospital for Neurology and Neurosurgery in London. I'm going to talk to you today about the use of magnetic resonance imaging in the evaluation for epilepsy surgery. The first time that magnetic resonance imaging was reported to be used for epilepsy was in 1984, and since then there have been a number of technical developments that made MRI essential for the study of the patients with epilepsy. In this presentation, I'm going to give you an overview about the MRI findings of the lesions that are causing most commonly epilepsy, the use of functional MRI and DTI to evaluate the patients with epilepsy, and the use of 3D multimodality images. An MRI is indicated whenever there is onset of partial seizures at any age, whenever the patient has a generalized tonic-clonic seizure in the first year of life or in adulthood, patients who are having a neurological or a neuropsychological deficit on examination. It should be always obtained when first-line medication for seizures are not effective in obtaining seizure control, and also in those patients where the therapy has been effective for a period of time, but there has been a change in the pattern of seizures. With regards to the protocol, a 3 Tesla MRI provides high-resolution images and should be preferred to the 1.5 Tesla if at all possible. The images should be acquired in a plane which is perpendicular to the long axis of the hippocampus, and there has to be particular attention in including in the field of view the entire brain in order to avoid missing subtle peripheral findings. In terms of sequences, most commonly utilized are a volumetric T1 image, a high-resolution T2, a fluid-attenuated inversion recovery, and if there is a suspicion of vascular lesions such as cavernovas, T2 stars weighted and gradient echo sequences can be particularly helpful. Okay, in the study of the patients, the use of diffusion-weighted imaging is essential to acquire DTI, spectroscopy, and also sometimes gadolinium-enhanced images in case of patients harboring a tumor. The structural abnormalities which are most commonly found in epilepsy are hippocampal sclerosis, malformation of cortical developments, tumors, vascular malformations, and other lesions. Hippocampal sclerosis is the commonest form of epilepsy in adults, and hippocampal sclerosis is the main pathologic finding associated with this. It is important to be able to recognize these abnormalities, as a surgical approach has 60% chances of rendering the patient seizure-free at about 5 years. Here is how hippocampal sclerosis looks like. You can see on this coronal T1 image that the left hippocampus is reduced in volume, and here you can see on the coronal flare that it returns an increased signal. And these days, there is also a trend on try and measure automatically the volume of the hippocampi. What you can see in this picture is this is how the hippocampus is represented from the tail to the head. In purple is the standard deviation of the normal hippocampi volume, and you can see in this picture that the left hippocampus is of reduced volume, while the right hippocampus is perfectly in the mean of the volume. Here you can see how the comparison between the left and the right. There are cases in which this is clearly very easy to detect, but there could be cases where both hippocampi look symmetrical, and having this possibility of measuring them, you would actually realize that there is volume loss on both sides, and that means that the epilepsy might be bitemporal. When it comes to malformation of cortical development, the classification is quite complex, and there is a lot of genetics these days that goes into it and helps and further differentiate this. I've used the classification of Barkovich that divides the malformation of cortical developments in 3 groups. Group number 1, there are malformations that are resulting from abnormal proliferation of cells, and this includes microcephaly, macrocephaly, focal cortical dysplasia, hemimegalencephaly, and disease such as tuberous sclerosis, and some tumors with dysplastic features such as gangliogliomas. The second group are malformations which are resulting from abnormal cell migration, such as lissencephaly and heterotopias. And the third group is the one resulting from abnormal cortical organization, such as polymicrogyrias and schizencephaly. Here are some examples. Focal cortical dysplasia is the most common malformation of cortical development in patients presenting with epilepsy, and is the most common cause of epilepsy in children. The images findings are often subtle, and it can be easy to miss a focal cortical dysplasia, so it is always important to review images in the context of what is the seizure semiology of the patient and the EEG findings. This is just because it's going to help the radiologist to focus their attention in that specific part of the brain and see if there is any small dysplastic lesion. This is an example of a focal cortical dysplasia in the right frontal lobe on these coronal flare images, and you can see the typical aspect of the tail that runs towards the ventricle. Group 2 is the one that encountered the abnormal neuronal migration. You can see in the first 2 slides the presence of heterotopic nodules around the ventricle and within the ventricle here. And in the third picture, you can see the presence of an heterotopia in band. There is this strip of abnormal grey matter within the normal white matter. This is again part of the group 2, so abnormal neuronal migration, and this is a case of lissencephaly, and on this axial T2 scan you can see that the brain has completely lost all the sulci and the gyri, and that the cortex is very thickened. This is an example of abnormal cortical organization, meaning a malformation of cortical development of group 3, and you can observe a case of schizencephaly where there is a split in the brain. Here you can see this abnormal sulcus that reaches the ventricle and is bordered by cortex on both sides. Tumors, as you well know, any tumor can be a possible cause of seizures. In the setting of chronic epilepsy, about a third of the patients are having tumors. In young adults and children, the common cause of chronic epilepsy are normally these embryoblastic neuroepithelial tumors and gangliogliomas. DNTs have a typical bubbly appearance. Here you can see a DNT in the left superior temporal gyrus. They tend to be hyperintense on T2 and flare sequences, and they tend to have a wedged shape, as you can see in this picture. Gangliogliomas, they often enhance and tend to have a nodule, a solid nodule, and sometimes a cystic component. Vascular malformations can also present with seizures. The commonest one you would find in epilepsy surgery are normally cavernomas, which tend to manifest in 50% of the patients with seizures. Seizures normally do not arise from the cavernoma in itself, but they tend to arise from the hemosiderin stain that surrounds the cavernoma in itself. And they tend to have a typical popcorn appearance, and they're very well visualized on T2 stars, T2 star and gradient echo sequences. Here is an example of a cavernoma. On the T2 axial, you can see the popcorn appearance, and on the gradient echo, you can see the hemosiderin stain that surrounds the cavernoma in itself. As an example of other lesion that you could encounter, I wanted to put a picture of an encephalocele, which is something that we're seeing more and more often because the quality of the images are improving. Here you can see that there is abnormal digitation of the temporal lobe within the temporal fossa, and you can see the same represented on the coronal plane. Often in patients with encephalocele, there might be signs that can suggest that the patient has raised intracranial pressure. Here is a young patient, and you can see that there is a disproportionate representation of the CSF spaces, that there is an empty cella, and then there is dilation of the optic sheath. These are all findings that can be sometimes associated with encephaloceles, and it is important to be detected. These were the most common abnormalities, and now we're going to have a look at the use of functional MRI and DTI. Functional MRI can be used to map language, motor function, memory, and also epileptic activity. The technique detects the area of increased neuronal activity, which are identified by an increased cerebral blood flow when the patient is performing a specific task. The type of images that are used, they use what is called a bold signal. And here you can see an example of an fMRI that has been elaborated. So this is a patient that has a very large left frontotemporal insular tumor. Interestingly, the patient was left-handed, and you can see in this example that the speech activation, both for verbal fluency and verb generation, are on the right side, supporting the fact that the patient should be right-sided dominant for language. Here is an example of motor fMRI, where you can see the activation of the hand area in relation to the tumor, and the activation of the leg area, again in relation to the tumor. Diffusion-weighted imaging measures the diffusion of water in the biological tissue and is normally used to delineate the white matter tracts. It's helpful in epilepsy to try and understand where language tracts, motor tracts such as the corticospinal tract, and visual pathways such as the optic radiation are in relation to the lesion or the area that needs to be resected. There are two different techniques to achieve a DTI image, and they're normally called probabilistic and deterministic. The one that is used more commonly in the clinical settings are deterministic type of tractography, which are easier to achieve. However, they have the disadvantage that they can be more inaccurate when there are multiple fibers that are crossing in the same area. This problem has been trying to be resolved by the probabilistic approach, which, however, is a little bit more complex to be applied and has therefore the disadvantage that it's a little bit slower in the whole process, and also requires the anatomic knowledge to know where the fibers are anatomically incorrect, and they can be filtered out of the 3D rendering. Here is an example of how different they look. This is a corticospinal tract obtained in a deterministic way and in a probabilistic way. The next part will be about the use of 3D multimodality imaging. What this means is the integration of different data sets into a single 3D visualization platform. In order to have this, there is a need of acquiring images, co-register all the images in the same space, segment the region of interest, and achieve a 3D visualization of the surface and volume renderings. I'm going to show you 3 examples on how this can be helpful in epilepsy cases. The first example is a case where we have co-registered multiple and different data sets on the patient-specific brain. The second example is how we use 3D multimodality imaging to facilitate the planning of stereo EEG electrodes. And the third example is how we use 3D multimodality imaging to facilitate the resection after implantation of electrodes. Now, this is the first example. So this rendering of the brain is clearly patient-specific. And what you can see in this picture is that we were able to highlight where the lesion is, which is this left frontal focal cortical dysplasia, and where was the area of activation of the SPECT, where was the hand motor, and where was the speech function in relation to the lesion in itself. Here you can see how we use 3D multimodality imaging to obtain, again, a volume rendering of the patient-specific anatomy of the cortex and the vessels. The vessels in our cases are normally obtained by angiography. And here you can see how the segmentation on the brain can facilitate the planning, and we are trying to automate this process. And here we are able to tell the computer which one is the superior frontal gyrus and the orbitofrontal region, and then the computer can obtain a trajectory through an avascular territory in order to be able to plan your stereo EEG. This is an example of a post-op case. So this is someone that was implanted with multiple electrodes in the frontal and temporal area. This is a reconstruction of the electrodes after they have been inserted, and here in purple you see the trajectories that we have pre-planned, and you can see how beautifully they align with our implantation. Highlighted in red are the contacts that the neurologist thought to be responsible for the onset of the seizures. Here is a volume that we created preoperatively of our resection that we wanted to achieve, and here is a post-op reconstruction of the resection that we achieved in this patient. Again, in this case, what I'm going to show you is we have highlighted only the electrodes where the seizures were starting. You can see the vascular anatomy beautifully represented, and this is the volume that we wanted to remove. These are all cases that are MRI negative, and the advantage of this technique that fundamentally you're giving yourself a target that then you know what you need to remove. This is just to show you how accurate are these 3D representation. This data is all obtained pre-operatively, so we've never seen the head of the patient, but when we open the dura up, we're able to beautifully reconstruct where things are. You can even see the entry point of the electrodes that we wanted to remove here, and you can recognize here the Sylvian fissure and the vessel, the vein that is, it's bifurcating here, and the long vein that continues backwards, which you can beautifully reproduce on this 3D model. And here you can see how the post-op picture of our cavity is very similar to the volume that we gave to ourselves to be removed during the operation. Another small part of this talk is going to be about the use of interventional MRI. The advantage of having an intraoperative MRI is that the patient can be scanned before the head is closed. The benefits are that you can achieve in real time, you can determine in real time what resection you have performed. You can detect if there is any residual lesion, and you can re-register the neuronavigation and correct for the brain shift, and you can also project your pre-op tractography down the microscope, and this gives you the possibility to protect as much as possible important tracts. Clearly, in pathologies such as epilepsy, when when it's lesional epilepsy, or even MRI negative cases when you have to make sure that you have achieved a complete resection, IMRI is essential because it gives you at the time of surgery the certainty of your complete resection. This is the settings that we have at Queen Square Hospital. We have a one-room solution. The patient is operated on this table that then turns around and slides into the MRI machine. These days there are different solutions. I think most hospitals have gone for a two-room solution just because at least they can utilize the scanner during the downtime of the operation. This is an example, is the same case that I've shown to you before, where we gave ourselves this target to be removed. And here you can see the intraop scan. So the head is still open here, between here and here. This is our craniotomy. And these red dots that you see here are the contacts that were responsible for the seizures. And you can see that we had the certainty that they were beautifully in the air. So the brain in that part was completely resected. And this is an example. This is the fMRI that I've shown to you before in the patient that was left-handed. And you can see that we've managed to perform a very large resection of the tumor. However, in the intraoperative scan, there was this small residua and the top and back that we were able to go and resect at the same time of the operation, avoiding a second look later. And this is the example of projecting your tractography within your operating field. Here you can see a model of the ventricle, and this is a model of the optic radiation. And you can see that in this case we have achieved a resection of the temporal pole, and we have been able to spare nicely the optic radiation, therefore reducing the risk of visual field defect. In conclusion, the role of MRI in the evaluation of epilepsy surgery has evolved over time and represents the technological advances made in the field. Structural MRI is crucial in the diagnosis of epileptogenic lesions, and it also guides further surgical management. In cases that are MRI negative, clearly there is need of other techniques on top of the MRI, such as PET and SPECT. The development of functional MRI and diffusion MRI has enabled and has facilitated the localization of eloquent cortical areas and also of white matter tracts. And the ability of being able to visualize these structures clearly has made surgery much safer. The use of 3D multimodality images has facilitated the planning of the cases, both of the implantation of the electrodes, but also of the resections. And the use of interventional MRI has helped to improve the outcome, being able to assess the completeness of the resection and also helping in preserving white matter tracts. I would just like to thank you for your attention. This is a picture of Queen Square in one of the rare sunny days, and if you want to come to visit us in London, you're all very welcome. Thank you very much.